let me introduce today's speaker. Ken Repking is a practice associate with LANDAUER Medical Physics Radiation Safety Support Services Group. He is certified by the Nuclear Medicine Technology Certification Board in radiation safety and has been working in radiology and radiation safety for over 24 years. Most of his career has been spent working in a community hospital where he served as the lead nuclear medicine technologist and later as the radiation manager, in which his duties included maintaining both MRI and radiation safety compliance. Today, he spends his time helping clients across the country with regulatory compliance and radiation safety program management. With that, I'd like to turn it over to Ken.
All right, thanks Edna for the introduction, and good morning everybody. Good afternoon maybe in some cases, depending on where you are. So we're here today to discuss, as we stated, the best practices in preparing dosimetry data for RSC meetings, Radiation Safety Committee meetings. I've been through many state inspections, TJC accreditation surveys, public health, CMS, many times. So along the way, I've gathered some knowledge and some tips that we'll share here throughout the presentation to help you maintain compliance in regards to your dosimetry program and assist you in preparing dosimetry data. So without further ado, let's get started. Okay, so we're going to start this off with a poll just to kind of gauge the audience. What is your current level of experience with dosimetry data and radiation safety committee meetings? Are you a beginner? Are you intermediate, or are you advanced and just here for a refresher? Edna, please launch that poll.
Yep, and that poll question has been launched. And thanks everyone for your participation in our poll questions. I will allow the audience about another 30 seconds before we close the poll. And Ken, responses are coming in. And let's see, we're going to go ahead and close the poll question. This is our first poll question. And let's see, let's share the results. So 44% of the audience, you're a beginner, 36 intermediate, and 20% is advanced. Thanks, everyone.
Okay, thank you. So we have almost 50% is beginner and a majority between beginner and advanced. And that's good. We're here to help. So here's kind of a quote I like to share. Good judgment comes from experience, and experience, well, we all know that comes from poor judgment. So if you're a beginner, this can seem like a daunting task. You may have just been assigned this. We're here to help. You may hit some speed bumps along the way, but that's how you learn. That's how we become more competent in our roles. We have all been there. And hopefully this presentation today will assist you and help you alleviate some of that concern. All right. So why are we here today? So one, we are going to present dosimetry matrix. We want you to understand what dosimetry metrics that we typically collect and present to a radiation safety committee meeting and why those are important. Then we're going to discuss these, and we want you to develop the ability to assess these metrics to support compliance with your program. Why do we look at these metrics? Why are they important? How do they apply? How do they help keep me in compliance? And thirdly, we're going to show you how to, a possible way for you to organize this data into a presentation suitable for your meetings that help keeps the audience and the members engaged while also disseminating the information and they're learning as they go. So what we are going to do today is going to be shown in the LANDAUER myLDR portal with what's called the RadFacts module. We're using that because that is the resource that we have available. That is where we collect our data. But your learnings can be applied broadly, regardless of platform. If you don't use that system, that's fine, but hopefully you get some tips and tricks to help you with the portal or system that you use. Okay, so another little quote that I like: the only thing that interferes with my learning is my education. We have all had a structured education, but the field of radiation and dosimetry is continually advancing. Things change, nothing stays the same. Therefore, it's crucial for us to remain flexible and open to learning new things to keep pace with these disciplines. So as we grow, new modalities, new technology comes in, we have to adjust accordingly. So metrics and things that we track now, we may not track, or we'll have new ones to track later. All right, so what types of dosimetry do we look at? The first one, you're probably all very familiar with, are the dosimeters, your personnel monitors. These are what your staff wear on the collar, on the waist, as fetal dosimeters, wherever it may be. And this is monitoring the occupational exposure and the thresholds that we have to maintain for the deep dose, the lands, the extremities, etc. Then there's also your patient dose. These are your fluorometrics and your CT metrics that are tracked according to your accreditation surveys, your accrediting body, to make sure that those thresholds are being met, and when those thresholds are exceeded, that you have documentation of why it was exceeded. And thirdly, there are area monitors. So most states, almost all states, you have to maintain a dose limit to members of the public, so which is usually 2 MR an hour or 100 millirem a year. So imagine this is an x-ray room. You may have visitors sitting here, you may have staff taking a break here. You need to ensure that the radiation, the scatter coming through this wall is not going over those regulatory limits. There's a few ways to do that. You can have a shielding design that you send to the state that shows, based on volume, that you're not going to exceed this. You can have a post-installation survey that shows what is coming through the wall, that shows you're in compliance. Or third, you can have an area monitor, which is similar to a dosimeter. It mounts on the wall and it detects what's coming through, and that can be measured. Now, one little benefit of that is, again, your shielding designs are based on volume. So as volume increases, if you had an area monitor, it could help you detect those changes to make sure you're in compliance. Okay. So it's important to understand the difference between a radiation safety committee and a quality assurance meeting. So we're all synonymous with the term RSC, Radiation Safety Committee meeting. It's what we all use. Whenever we have a safety meeting, that's what we use the term. It actually comes from the NRC regulation 35.24, and this is specific to radioactive materials. So licensees that have 2 or more types of radioactive material must have a Radiation Safety Committee meeting by regulations. And with that, they also have to have a radiation safety officer. Now, let's say you're a surgical facility, you don't have RAM, but you may still have quality assurance meetings. You review, you analyze the same metrics for your accreditation and for best practices. This is where the term individual responsible for radiation protection comes from. The IIRP, by regulation, you do not have to have a designated radiation safety officer. So for today's webinar, we're going to use radiation safety officer and radiation safety committee meeting just as a general term, but I just wanted everybody to understand the difference. So what we discussed today, even if you don't have an RC, will still apply to you. Okay. So what are the occupational limits that we look at? These are one of the metrics that we have to monitor. We have to stay below these thresholds. So for whole body, in almost all states, 5,000 millirem a year or 5 rem a year. For your extremities, these are your ring dosimeters and such, 50,000 millirem a year or 50 rem a year. And for the lens of the eye, we actually developed, we have a dosimeter that goes on the lead glasses that physicians can wear if they want. And it's monitored 15,000 millirem a year or 15 rem a year. So these are pretty standard across the states. However, you need to be aware of your state regulations. For instance, Indiana actually limits the amount per quarter. They have the same annual limits, but their amounts per quarter differ. Okay. And to keep this kind of just entertaining and keep everybody awake and engaged here, here's another little kind of tidbit. It is illegal to fall asleep in a cheese factory in South Dakota. So if you find yourself in South Dakota on a cheese tour, do not fall asleep. That's a good way to get in trouble. Little dad joke there. All right, moving on. LAR levels. So your LAR levels are your early warning system. This is what keeps you on track and helps prevent you from going over the annual limits. So these level 2, these are your annual LAR levels. These are based on, your level 2 are 30% of the annual limits that we just discussed. Your level 1 are 10% of the annual limits. And then for the quarterly LAR levels, it's just simply the annual level divided by 4. So per quarter, you would be limited to 125, you would reach to 500. For level 2, 375 a quarter would get you to 1500. These levels are established. If you hit these and you stay on the same track, you have potential to exceed the annual limits. So that's why we review these and monitor these. Now we also add in fetal levels. So for fetal monitoring, you should keep it below 50 millirem a month because the max is 500 millirem. So we like to set LAR levels for those, level 1 at 30 and at 40, so that we can keep track and again, prevent that overexposure. Now, these are default levels. When you have a LANDAUER dosimeter, everything here, besides the fetals, are defaulted. Now, if you want to customize those, you can, which is very common for very busy cath labs, interventional, you have higher exposures. So you can get what is called an ALARA fatigue. The physicians are getting so many ALARA 2 memos and investigations are being performed and they're signing off. You can raise these levels to minimize those ALARA memos. However, you want to ensure that you do not go too high because again, you want to be proactive and you want to catch it before it reaches that high exposure. So typically some facilities will just double this number. All right. Visual aids. Visual aids, data charts, graphs, these are crucial. These make a presentation engaging and informative. You can use this in our portal, you can use Excel, whatever programs that you may have available. So I'm going to show you an example here. So let's say we're in our meeting and we're going over the data. And you can see for quarter 2, 23, we had 9 ALARA 1s, 3 ALARA 2s. Change from last quarter, 11 ALARA 1s and 3 ALARA 2s. And since we're discussing that the previous 2 quarters had 7 and 9 ALARA 1s and no ALARA 2s. So everybody got that, understand? Or, sorry, you can do this. So this is the same data presented in the visual format. So you can see that we've had a trend upwards. We started to decrease downwards, which is positive. This is what we want to see. We decreased from ALARA 1s from last quarter from 11 to 9. We have had a steady level of ALARA 2s, a little bit higher than quarter 4. So that's something we may want to look at. So it's just an easier way to understand the data and to also trend it. Okay. RSC meeting template. These templates are important because we want to avoid this. Raise your hand if you've ever been in a meeting to where this could have been an email. So there is a rule of thumb. If you don't have an agenda, you don't have a meeting. This is what helps keep you organized and on time and ensure that you cover the necessary information. And we're going to go through these in depth, but these are little typical to an RSC meeting. You open the meeting, you go over any old business, then you start any new business, any safety issues, you go over your fluoroscopy CT monitoring, were there any overexposures, you know, were patient letters sent out, your nuclear medicine license review, and you have your dosimetry section, which is what we're going to discuss in depth today, your dosimeters, the readings, what information we have, any annual reviews, how is your LAR program looking, any PMP, etc. So another tidbit here. So somebody is going to be assigned. So let's say you are this person where it says LANDAUER. You are assigned to the dosimetry portion. We're going to show you the presentation. It is a PowerPoint presentation. There are also other people that have to present. So you may want to collaborate with them and put it all into one presentation or part of it into one presentation. That way it helps the the meeting be more effective. Okay, key components of the Radiation Safety Committee meeting or your quality assurance meeting, whatever it may be. So you want to ensure that you're meeting on time, whether it be your regulatory, whether it may be specified by your accrediting body. Are you meeting the frequent amount of time, and are all required members present? Then you typically go over old business as stated, any LR exposures that needed to follow up on, and you can report out. Dosimetry review, we're going to go through your LR performance, returning dosimeters on time, declared pregnant workers, any unused dosimeters, and what do the dosing trends look like across the collective staff. Okay, policy procedures reviews and updates, annual apron inspections, have they been started? Are there any issues? Do we need to get rid of any? Your annual radiation safety training. Don't forget ancillary training is an important part of this. Your equipment performance evaluations, your dose monitoring thresholds, your CT, your fluorometrics. Again, the license review, if you're doing therapy, how many I-130 cases were performed, any issues, any documentation issues, any incidents, and any safety concerns across the organization concerning radiation safety. And also, as part of the RFC, in order to cut down on the amount of meetings you have to attend, many facilities will include MRI safety and laser safety as part of this. That way, most of the stakeholders are involved in both, so it just helps minimize the meetings you have to attend. And then any new business and how this applies to dosimetry data. Again, do you have staff who are wearing 2 dosimeters? Maybe they're wearing them incorrectly and they need to go to 1 dosimeter, or maybe you have a physician who's receiving really high doses in fluoro, so you want to go to the 2 dosimeter system and therefore apply EDE calculations on either one. Do they need EDE calculations? And also go over your area monitors. Are you compliant with the dose limits to members of the public? And are there any other discussions that need to occur, such as do anesthesia personnel need dosimeters? Is there anybody that's not wearing a dosimeter that we feel should have one? Okay, presentation pitfalls. So hopefully you're all kind of this guy right here and not these people. Okay, participant privacy. So as we're showing the data and presenting the data, there can be sensitive info in there, such as social security number and date of birth. You want to make sure you don't display that when you're doing the presentation. You want to be careful of information overload. Just present what's necessary. You only have a certain amount of time, so just stick to what's crucial to the moment. Know your audience, avoid technical jargon, unless they're all familiar with it, avoid the acronyms. Do they all know what milligray and gray are? Do they all know what RSC and IRP are? So just know your audience and be careful of that. Not being prepared. We talked about how the template, the agenda is gonna keep you organized and process the meeting well. Visual aids, we showed you how it can just keep the audience more engaged and provide a better understanding of the metrics. So you're going to have a lot of stakeholders, leaders, colleagues in there. It's a great chance to answer questions. Don't ignore them. Stakeholders can provide input to questions that are asked. And overlooking the implications. So there's a lot of information discussed. This can have financial implications for your hospital. The information can have accreditation implications. So it's important that this data gets disseminated. Okay, and of course, getting in a rush, rushing through where people don't have time to digest what was just thrown at them. All right, time for another poll. So what are the main challenges you face currently when preparing dosimetry data for Radiation Safety Committee meetings? Is it the data collection and organizing it? Is it the analysis and interpretation, presentation and communication of the results, or all the above, or a mixture? Edna, please launch that poll.
Okay, and that second poll question has been launched. And once again, we will give attendees about 30 seconds to enter their responses. And we greatly appreciate your feedback. So please, your engagement and our poll questions is really helpful for us. Also, as you're entering your responses, I want to remind everyone, if you do have questions, please feel free to submit your questions to the questions panel, and we will try to answer as many questions as possible during the Q&A session at the end of the webinar. So I'm going to go ahead and close the poll and share those results. So 21% of the audience indicated data collection and organization. 23% indicated data analysis and interpretation. 13% indicated presentation and communication of results. And 43% indicated all of the above.
Okay, great. Thank you for that. And again, so we said this can be a daunting task, right? We've all been here. Raise your hand. Been here. Hopefully today's webinar and what you're going to learn can help, again, alleviate some of this to kind of help you in understanding and prepare you better. Okay. So what we're going to do now is we're going to go through the metrics that we track and give you some tips on them and why we do this. Again, this is shown in the myLDR RadFacts portal. So if you have this, great, maybe you can get a better understanding of it. And if you don't have it, that's fine too. You can still take pointers from the actual metrics. Okay, so we're going to start off with the overview screen. And again, you always want to make sure that you're in the right year. Some systems, you know, you get into the new year and make sure you're working with the correct data. So this provides a high-level overview. We talked that we do not want to rush through meetings, but again, that can happen. You know, you're in a meeting, then over the speaker, you get, welcome the Joint Commission to the building, right? Now we're scrambling. We got to rush through this. So this can help. This gives you the total number of participants, total number of dosimeters, the percent of unused dosimeters, the percent late. These are your annual ALARAs. This is your collective dose. This is dose across all participants. And it shows you where the dosimeters are broken down by sub-account. So you can see surgery has 163. Again, this is helpful if you want to just do a snapshot of the entire program if you get in a hurry. You may be wondering here, why this big difference? You need to remember that not everybody wears one dosimeter. You also have ring dosimeters, you have spares, you can have visitors, you can have fetals, you can have area monitors, etc. And one thing we're also going to discuss, and this is where it's important to understand data. So you can see here, 416 participants, 38% are late. That's a high number. That's around 158% late. Now, what if you were a small facility and you had 10 participants and 50% were late? Yeah, it's a high number, but it's only 5 participants. It's a lot easier to track and kind of reel in the process versus 156. So again, just be cognizant of those numbers and understand the data. Okay, moving on to ALAR compliance. So this is a demo account. So we're just going to pretend it is Q2 for 2023. You can see Q2 2023, we had 10 ALARA 1s and 4 ALARA 2s. Now, what are we looking for in the ALARAs? First thing I'm going to do, I'm really concerned about the ALARA 2s, the ALARA 1s. Yeah, I'm aware of, but these are the ones I want to focus on. So 1, you have your ALARA 2 participants here. Did they receive their memos? Was follow-up performed? Was the investigation performed? Do you have any area monitors? See, we have an area monitor here. It hit an ALARA 1, but it doesn't look like it's out of compliance by any means at this point in time. And also, we're going to be cognizant of the quarterly dose and the year-to-date dose. So we are in Q2 of 23. This participant received 829 for the quarter, 2148 for the year. So again, at Q2, they've almost reached half of their annual limit. The annual limit would be 5,000 millirem. Once they hit 2,500, they're at half. So I really want to dive into this and see what's going on to kind of see if we can get that dose lower. Now, let's say this is at the end of Q3 and we're at the same level. Now we only have 3 more months. The chances of them exceeding the annual limits are not as great. I still am going to follow up to see if we can keep the dose low, but my fear of going over the annual limit is lessened. Now, again, these LAR levels are based on what you set with LANDAUER. We showed you the default. Again, you can customize these LAR levels to meet the needs of your facility. Okay, so this is return compliance. These are late and unreturned dosimeters. So for LANDAUER specifically, any dosimeter returned 45 days after the wear period is considered late. Now, those are the yellow ones. After 45 days, these red ones have not been returned yet. So we have 28 that have not been returned. This is important. These are important for a few reasons. Any dosimeter returned less than 90 days from the wear period does not receive the late fee. Any dosimeter returned greater than 90 days out after that wear period incurs a late fee. So it can have financial implications if you do have a high number. Also, we want to be proactive. We want to get these dosimeters back in a timely manner in case there is a high exposure. You don't want to have the high exposure 6 months down the road. Their dosimeter was found, returned 6 months, and then you're like, hey, what's going on here? Well, now we have to really backtrack and see what actually occurred. Okay. Now over here, it is dived into by sub-account. You can see that 100% of the rehab sub-account dosimeters are late. This green line here is an 8% threshold. That threshold is established based on LANDAUER's domestic and global clients since 2008. It's not a scientific study. It is an internal threshold that we use. Okay. And another thing to keep in mind, we have 200 participants that have late dosimeters. We're not going to go through all of these in the meeting. We're going to take a little screenshot just to kind of show some of the highest offenders and go over that. This report can be printed out, and then you can delegate that to the appropriate personnel to kind of investigate why these dosimeters are late by the sub-accounts. And another thing, as far as trending and the visual data. So you can see from Q4 to Q1, something went wrong. Something did not work. We had a high increase in late dosimeters. But then from Q1 to Q2, it was almost half. So whatever was initiated here, whatever process worked, and you want to celebrate those wins. All right, let's move on to declared pregnant workers. Okay, so this is going to show us our declared pregnant workers. It looks like we have 3, 2 in surgery, 1 in interventional radiology. So this is important because we want to make sure these are declared pregnant workers, that we have the declaration forms on file. We want to look at their total exposure. These are all minimal, so no concerns, but let's say one was high. You have to evaluate, do job duties need adjusted? Are they in nuke med? Do they do therapy? Do we need to possibly limit or pull them out of therapy? And also, you can see here that you see 262 days here. Well, after 280 days, that's 40 weeks, 7 days a week, that's 280. That is the threshold for the the declared pregnant worker dosimeter. After 280 days, we would suspect that the participant would have delivered. If not, this flags you, because a couple things can happen. One, we get busy and we forgot to cancel that dosimeter and we're still paying for it. So again, a financial implication. Two, perhaps it was canceled but not canceled properly. When you cancel the fetal dosimeters, you have to cancel it. You also have to put in the end date of the pregnancy because it's a safety mechanism. So we get in a hurry, we click the wrong button and we canceled it unknowingly. The dosimeter, the whole body dosimeter now that the participant is wearing is still going to accumulate dose, and that dose is going to be reported as fetal exposure because we don't want to miss that exposure. So then you would just have to go in and cancel that dosimeter properly. All right. Let's move on to unused dosimeters. So you see for quarter 2, 23, we had a couple of unused dosimeters, or 182 unused dosimeters. And I am going to backtrack really quick. So when we get back into the presentation, I'll backtrack. I'll just move on for now. I'll show you something. So the unused dosimeters are based on an unused tab, which I'll show here after this. So why are unused dosimeters important? You can see here surgery and outpatient are the highest offenders. They have the most unused dosimeters. You can see down here, shows you who they are. So we need to evaluate if you have spares. Let's say you have spare 1 through 5, spare 1 is missing from this unused list. That means it was used. Now you need to ensure that it was assigned. Also, we have a list of unused dosimeters. Why are these participants not wearing dosimeters? Were they on medical leave? Were they on furlough? Have they just in different job duties currently? Because you would expect that an interventional RAD subaccount would be wearing a dosimeter. So the inspectors and the surveyors will come in, and the first thing they do is they head to interventional cath lab high exposure fluoro areas, and they look to see that everybody's wearing a dosimeter. And if not, then that can be a deficiency. Okay. Also, you want to evaluate for any unused fetals that may show up in here to kind of signify that those need terminated. And then also, one other piece that the NRC actually came out with last year or the year before, they are also looking at the exposure of these dosimeters in these high areas such as therapy and fluoro. If you are working in an interventional lab and you have all minimal across all quarters, that's going to throw a red flag because they would expect to see a higher reading on those, and it may signify that people are not wearing the dosimeters. Okay. And again, like before, we had 182 participants. We're not going to go through all of those in this meeting. We're going to print that out and again, delegate. And a couple of questions that have come up about these. Physicians do not wear these. How can we address that issues? And that's providing knowledge. The dosimeters must be worn by conditions of monitoring, which are listed in your regulations. And if they are not doing that, this is an accreditation deficiency. This is a regulatory finding, which can also have a financial impact. It can affect your reimbursement depending on what their accreditation body does, et cetera. And many times they're unannounced spot checks. The Joint Commission or the state will just come in to check on things and can find this if the dosimeters are not being worn. Also, another question, people have different locations. They have multiple locations. Is it necessary to have a dosimeter for that participant at each location? I would recommend yes, because you're tracking the outliers. You want to see the high exposure. If you have one dosimeter and you're traveling to 4 different clinics, now you have a very high reading. Where did that occur at? It just makes it easier for you to track it if you can specify, you have a dosimeter per location. I know exactly where that exposure came from. It helps with your investigation. Okay, moving on to collective dose. Okay, so this shows the total dose across all participants. You can see for the Q2, we had 305 participants. We had a collective dose of 5.3. So each participant's allowed 5 grams, so I really don't have any concern with high exposure. This piece here breaks it down. This shows it just in a different format. You can see 27 in the 1 to 10 range, 21 in the 11 to 50 range. The highest amount of dose is in the low range. We have very little on this higher end, which is what we want to see. But you can see here, this can help identify trends, seasonal variations, changes in work procedures, equipment. We have relatively the same amount of participants, but we had a decrease in dose. Now, why would that be? Perhaps it's summertime and you have, your volume's lower, or perhaps you got some new lead aprons and that reduced dose. Perhaps there was some dose reduction software. Whatever it may be, this kind of training can help you evaluate that. All right, we're going to go back into the PowerPoint presentation here. And I am going to backtrack just a second here because there's something I want to show you. Okay. So I want to talk about these dosimeters here real quick because these are also common questions that come up. You can see this dosimeter is in the holder. When the dosimeter comes to you, it's going to have a tab on the top here that has to be broken off. When that is returned with that tab intact, it is unused. It is processed as unused. So, and the only way to get it in this holder is to break that tab. And then another common question is this control dosimeter. What is it? Why do we have it? What do we use it for? So when these dosimeters are shipped to you, they can oftentimes be shipped by air freight. You can have some cosmic radiation due to higher elevation, closer to the sun, et cetera. So these dosimeters can get an exposure. It's not true exposure. It's not to the participant themselves. So this control dosimeter is shipped with these, and it accumulates that exposure. Then when you get it, you store it in a protected area, free from scattered radiation. And then when it's returned, that whatever reading is on this dosimeter is subtracted from the others in that same sub-account, because that is not true data. That is just from transport. And we want to be able to track that, providing the most accurate data there is. Okay, this is where we left off. Now what we're going to do, we've shown you all this, and hopefully you have a better understanding. So now we're going to pretend that you all are the Radiation Safety Committee meeting, and I am presenting to you. I'll act as if I'm doing a presentation with a couple one-offs in case I need to discuss a few things. First one here, you'll see this is the account number 123456. This is important because you will do a presentation per account, because that's tracking that account, all the LRs and everything. So you may have to do this multiple different times, but you want it account specific. You don't want to throw it all into one unless there's a reason you can, depending on how your account is composed. All right. So this is the Radiation Safety Committee meeting for ABC Hospital 2023 Q2. This is account 123456. So you can see that we have 5 annual ALARA 1s, 1 annual ALARA 2, 416 participants, 14% of the dosimeters are unused, 38 are late, 38% are late. We're going to discuss that in a few slides with 3 pregnant participants. Okay. Looks like we had 10 ALARA 1 and 4 ALARA 2s for the quarter. Not much change from the prior quarter. Looks like Rogers has an exposure of 2148. That's potential to exceed the annual limits based on the current accumulation. So we really want to dive down and investigate what's going on here to see if we can change some practices. Everybody else, no concerns at this time. Okay, looks like for Q2, we had 173 late dosimeters, 28 yet to be returned. It looks like those are coming from rehab subaccount. However, We did have a significant improvement from Q1 in late returns, much improvement. Kudos go out to the processes and the people responsible for that. Okay. We have 3 declared pregnant participants. Just ensure their declarations are on file. Nobody is receiving any high exposure. They are all at minimal. However, it looks like Erskine and Foreman are beyond the expected gestational days. So we would want to reevaluate those pregnant dosimeters to see if those fetal dosimeters to see if we need to cancel those or if they weren't canceled properly. Okay. Again, so 182 unused dosimeters for Q2, improvement from Q1. Let's keep that up. It looks like surgery and endo-patient subaccounts are the highest offenders of the unused dosimeters. Again, keep in mind, we need to understand why these dosimeters are not being worn. This can cause regulatory and compliance issues. Okay. And then our collective deep dose analysis, there was a collective dose of 5.3 with 305 participants. So no concerns with high dose at this time. Majority of the exposure is in the lower range and a little bit of lower dose from Q1 2023. Okay. And then you can place these kind of things. So that would be the end of the presentation there. And then we would go on throughout the meeting. But you can place this at the end of your meetings if you like. You can have little check boxes. This is what needs to be done this quarter, or this is just kind of something to review. Obviously, you want to monitor your ALARA 2s, make sure all the letters were sent to the staff and that education is provided. So we keep that dose low. You want to evaluate the late dosimeters from the top offending subaccounts. You want to really focus on the dosimeters that are less than 90 days past the wear date, so you can result in a savings to your hospital. You want to closely monitor pregnant participants, ensure all declarations are on file, ensure that their exposure is low, that they're not at risk for reaching that 500 millirem threshold. And again, unused dosimeters, why are they not wearing them? Find out why, compliance, regulatory, accreditation issues there. And looking for trends and evaluating the trends. Why did we have the dips? What was going on? And manage the ones at the higher level. Okay, time for another poll. So after attending this webinar, and this is the final one, after attending this webinar, how confident are you in your ability to interpret and present dosimetry data? You're very confident, you're much better, but still have some questions, no change, or you still need more training. And Edna, please launch that poll. And we hope that you all are as happy and feel as good as this little guy here.
And Ken, that poll question, as you indicated, our final poll question has been launched. And let's give participants on the call about 30 seconds to enter their answer. Once again, thank you for engaging in our poll questions today. And then we will get into some of our questions. Lots of questions, so we will try to answer as many questions as possible. So feel free to go ahead and enter your questions in the questions panel. So Ken, I'm going to go ahead and close that, the last poll question. I'll share the results, and 35% of the audience indicated they're very confident. 55% indicated much better, but still have some questions. 5% indicated no change, and then additional 5% indicated I still need more training.
Okay, great, thank you, Edna. So it looks like most are in this area where they feel pretty comfortable, and some of you are not, and that's okay. We provide assistance and segue into our next piece here. So again, I do work for LANDAUER Medical Physics, the Radiation Safety Support Services side. We can help you with site-specific radiation protection programs. We can assist in managing your radiation dosimetry program. We can virtually attend your RSC meetings. We can help guide your program to regulatory compliance. We review policies, procedures. We facilitate RML amendments and license renewals. And if you ever need assistance with these kind of things, you can reach out to this email right here. I'll leave that up for just a little bit. rsservices@landauermp.com. MP stands for medical physics. And just a few more seconds. And all right, so let's move into the Q&A and see if anybody has any questions.
Absolutely. All right, so our first question is, are inspectors attentive, or do they concentrate on unused dosimeters?
Yes, very much so. We kind of addressed that. So the unused dosimeters can show that people are not wearing them when they should possibly be wearing them. Also, again, that minimal dose in a typically higher exposure area can raise a red flag and lead to a deeper investigation by the inspector or surveyor.
Okay. Next question. Can you provide any recommendations for software tools or platforms that can help streamline the process of preparing dosimetry data for committee meetings?
Yeah, so, we showed you the RadFacts, which is myLDR, and again, that's our resource. If you don't have that, if you are with LANDAUER, it is something you can look into purchasing. If you don't have it, Excel is a great program. Your provider, if maybe you're not with LANDAUER, you're with another organization, perhaps they have something that you can look into. And there's usually an Excel guru around within your organization. I always reached out to our performance improvement department. This is what they do every day, or create these kind of visual data graphs and charts, and perhaps they can help you set up a template. Once that template is set, then it's just punching in some numbers and hitting a button. So,
okay.
Good question.
Next question. How can we better communicate the significance of dosimetry data to non-technical members of the Radiation Safety Committee?
So again, we briefly touched on it. You want to avoid the technical jargon that they may not understand. Just use the simple language. And as far as, they may not understand dose, you can explain it in a different way, such as a level of a sunburn, right? You have a little redness and you may get into blistering. That they may understand that may resonate with them better. So basically just understand their background and tailor the conversation accordingly to their specific needs. And the visual aids can also help.
Okay. What are some common pitfalls or mistakes to avoid when presenting dosimetry data during committee meetings?
Okay. So again, too much info, information overload, you want to avoid that. Just keep the unnecessary stuff out. Technical jargon, data privacy is a big one. Just ensure, you saw the presentation, just ensure that you're not showing social security numbers, date of birth, things like that, and not being prepared. Again, that template is going to help you just stay organized and flow through the meeting and not miss a step.
Okay. Next question. How can we foster a culture of continuous improvement and learning within our organization when it comes to radiation safety and dosimetry practices?
Okay, good question. So I would recommend open communication and regular training. And again, recognize and reward those improvement efforts. We have to point out what's wrong, but you also want to point out what's right. And when something goes right, celebrate that. Let the staff know. Then they're more conducive to learning, and they're hey, this is great. Invest in the technology. There's things out there, and budgets are tight, but sometimes we have to, kind of move forward with those sort of things. And lead by example, participate in the training with the staff, show that you're concerned and you support the learning and you're not asking anybody to do something that you do not do. So good question.
Okay. The next question, what does ALARA stand for?
So ALARA stands as low as reasonably achievable. So what that means is you're taking the steps, you're using lead shielding, you're using time and distance, you're using dose reduction. You're doing everything you can to keep the exposure to your staff as low as you can within reason.
Okay. The next question is, do ALARA investigational levels only apply to those that are under NRC regulations?
So the answer is no. So typically with the NRC, with any state, you're going to have a radiation protection program. And one of the biggest points of that radiation protection program is your ALARA compliance. And so with that being said, yes, you do have to maintain ALARA. And so the ALARA ones, the sidetrack here a second. So the ALARA ones, the memo generates, but it's just to notify the participant, hey, you're at that level. The ALARA 2s are where an investigation has to happen because that's getting into higher levels. That's what's going to throw them over the limit. So those are the ones that you're investigating, you're meeting with, and they're signing off. The ALARA 1 basically just said, hey, Joe, you got ALARA 1. We need to be more cognizant of our processes.
Okay. This is a pretty long question, so bear with me. My workplace does not fall under NRC regulations, but we would still like to get a baseline for exposure for our employees that work with industrial cabinet X-rays. How long would you recommend conducting a baseline dosimeter assessment?
Okay, so this is a great question, and we actually get this fairly often on the industrial side. So within, you're not an NRC state, but you still may have industrial state regulations. So I would still look at that. And within regulations is something called conditions for monitoring. This is saying these are the people that have to be monitored, and it's typically, depending on your state, can be 100 rem a year or 500 rem a year. If you have the potential to reach that exposure, you must wear a dosimeter. Now, when you get into the cabinet and the world, they're pretty self-shielded. You have minimal exposure, so you may not meet that. So typically what we recommend is I would do a minimum of 6 months, preferably a year of dosimetry data. If you can show that, hey, we have monitored all of our staff for a year, they're all below the required level by our state, so we are not wearing dosimeters anymore. So then when the state comes in, you can show them that data. The piece you have to be careful with is when that's based on your current equipment. You have to ensure if you're getting new equipment that nothing changes. For instance, it's not a higher energy, it's not an open cabinet versus a closed cabinet and things like that. So changes you have to be aware of that may affect their exposure upon those changes.
Okay. Another question regarding the dashboard. Can the dashboard view be exported to use on a slide or a presentation for RSC?
So the overview, you can screenshot it 100%. You can screenshot that. I don't believe there is an export, but you can screenshot it and you can print it to PDF, or you can paste it as a JPEG, whatever. But yes, you can take that data out of the dashboard.
Okay. Another question regarding RadFacts. Wondering, how do I access RadFacts?
So if you are interested in that module, reach out to customer service, or if you have a sales representative that you work with, then they can kind of get you some pricing on that. Whenever you go into myLDR, when you have it, it'll be on the left-hand side. It's another tab that you would see once it's activated.
Okay. A couple more questions before we wrap up. Are there different levels for the dosimeter accounts? I don't have RadFacts on my account.
Yeah, so again,
Mm-hmm.
that would reach out to your customer service rep or customer service for pricing. Based on your account, you know, the different accounts have different contracts, so they would be able to tell you what kind of pricing group you're in.
Okay. How are late dosimeters calculated? After how many days is a dosimeter considered late?
So the dosimeter is late after 45 days. So on your dosimeter, you have a wear period. When it's returned 45 days after the end of that wear period, that's a late dosimeter. Then when you reach that 90-day mark, now there's a late fee when it's returned. So anything returned greater than 90 days, there's going to be an extra charge because of processing and things that happen on the factory side to deal with the late dosimeters.
Okay. Two more questions before we wrap. What is the mandated frequency of the radiation safety meetings?
So that is going to involve your state regulations. So the NRC actually does not specify. That is specified in your program. You determine how often you need to meet, and then it's part of your conditions of your license. When you apply for a radioactive material license, you also specify how often you meet. And some states do say you must meet quarterly. So it's state specific. I would, if it's not specified, I would at least, I would at least meet twice a year. Quarterly is the best practice. We meet every quarter to discuss any issues. The reason I say meet at least twice, because you don't want to get to the end of the year, you have your radiation safety committee, and hey, we've got Dr. Jones is over his limit, but we're just now finding out about it because we've never met before, we've never discussed it. So again, it's that proactive approach to prevent those things from happening.
Okay. Last question. This is regarding ALARA again. What does the letter or your communication need to state if you do have someone with an ALARA too?
Okay. So if on the LANDAUER side, if you have an ALARA memo generated, you can have those generated. It has a question form there, but basically it goes over basically what happened. Did you lose your dosimeter? Did you wear it in your car? Did you leave it somewhere? Have you noticed higher volume? Do you have